We started this initiative by trying to determine, is there a way to build a collaborative care network in Florida for adults? Because there's already a telephone-related integrated care hub in pediatrics. And it's not a traditional collaborative care model, but it's an integrated model to bring together psychiatrists and pediatricians to help them solve mental health problems of the children and adolescents that they treat. As we in the Florida Psychiatric Society looked at the Pediatric Behavioral Initiative for Collaborative Care, we decided that there should be a way to build a similar type telephone hub for adults. And as we were researching that, we came to realize that there are several things we would need to do, not the least of which is to be able to get some funding to do that kind of program. As we were examining the potential for building such a hub that could grow later into a full-fledged collaborative care program, we got introduced to a program called Project Echo, which is an international program that's designed for doctors who are specialists in one area or another to teach primary care doctors about their specialty area and help them, particularly those in more rural areas, provide some of the care that they would otherwise be referring to mental health professionals, but can't find those mental health professionals in the rural areas, and sometimes not even so easily in the more urban areas. Project Echo is an international program that was first founded by Sanjeev Arora, a gastroenterology professor at the University of New Mexico and a hepatology specialist. He had a case about 10 years ago of a woman with hepatitis C who came for consultation at the University of New Mexico and was found at that visit after 8 years of already having hep C to have liver cancer, to which she succumbed to within a few months of the consultation visit. And he asked himself the question, why couldn't the more rural doctors that she had seen 8 years ago have used already well-known established treatments for hep C to prevent all this from happening and save her life? And as a result of that, he founded Project Echo, which has grown into an international program for teaching primary care doctors and others what specialists know in different subsets and subfields. When we learned about this Echo model just recently, we began to realize that it would be a way for us to begin to build our collaborative care network in Florida, because a collaborative care network requires psychiatrists and primary care doctors to communicate with each other. And we have decided that we are going to found an Echo hub through the Florida Psychiatric Society. And we are going to get some intensive training in Project Echo over the next few months. And then we are going to try to launch our first program maybe somewhere around September or October. We're going to have to do some type of needs assessment because we need to figure out from the primary care community what they need the most. What do they see the most? Are they seeing problems with cannabis? Are they seeing problems with Suboxone? Are they seeing patients with bipolar disorder? Are they seeing patients with depression that they're starting to treat, but then they don't know what to do when the first drug fails? Are they seeing people with lots of anxiety disorders, but they don't know what else to do besides give benzodiazepines or inadequately low doses of SSRI medicines? So this is the background in which I come to you as the president of Florida Psychiatric Society, telling you that I would like to find ways to team up with the Florida Medical Society, Florida Medical Association, and the family practitioners to bring psychiatrists together with primary care doctors to teach y'all more about what we know about psychiatry, because you're already doing a lot of it anyway. And how can we get you to be better at it because you can't necessarily get consultations with us so easily.
I love this so much, and I think it's just so important. And in fact, I just had a resident, internal medicine resident, who's about to graduate, and she was asking me, is there anything right before I graduate? I got a couple months left. Are there any electives that you think are sort of non-negotiable for primary care? And I asked her, did you have any psychiatry in residency? And she said no. And I said, that would be my strongest recommendation because psychiatry is incorporated into so much of what we do in primary care. So my first thought is always asking myself, which is what you just asked, what is the current situation with practicing physicians from new graduates to those who may be out for a little bit longer, as far as what are their needs, what education and training have they had when they graduate? Do you have any thoughts on that, or have you spoken with any residency directors in primary care?
I have not actually. That's a really wonderful idea when it comes to needs assessment, is to drill down on the residency training programs, even just here in Florida, to find out what they are in fact teaching. I know that when I was introducing the collaborative care model to the Florida Psychiatric Society, that many of the training directors became acutely interested in the program. And even the American Psychiatric Association is conducting an initiative with one of the early authors about collaborative care, where they teach residency training directors how to train their residents in collaborative care. And as we speak, we have a few training directors here in Florida that are exploring in their communities with some of the primary care groups how they can integrate their residents into the primary care clinics as part of their training.
Yeah, I think that's such a great fundamental starting place. And, to tell you more about that resident, she said she had a little bit of psych experience, but it was all doing some inpatient work, which is good. I mean, it's good to know how bad things can get and to know what is serious and needs inpatient. But I think where we're losing opportunities is in the outpatient realm and figuring out, how to get those opportunities for experience. So, other than finding out where doctors are as far as their knowledge base, what other ways are you thinking about figuring out what the needs are, like a survey of members or of doctors?
One fantasy that I had is about the Florida Medical Association itself. Florida Medical Association has a fairly sophisticated webinar series where a specialist of some kind, whether it's in practice finance or it's in hepatology or it's, as I gave one in the webinar series about collaborative care, uh, in these weekly or monthly programs that FMA conducts, uh, there's a maybe an opportunity at the end of any particular webinar to put up a few questions to the participants. Oftentimes there are a few hundred participants where we would simply ask them a few questions about their experiences in training or what their needs are for their particular patient population, because we're going to build some future webinars or echo project programs in that area.
Yeah, I also wonder about having maybe a psychiatry track or path at some of the CME meetings for example, the Florida Academy of Family Physicians or ACP. Maybe there's also a way to incorporate there, because those are doctors going to meetings anyways, and maybe there could be a track, or each different conference could have a different psychiatric topic of common issues in primary care.
That is a really wonderful idea. Even we in FPS sometimes bring people in other specialties to come in to talk to us about things that are integrated with mental health matters, but they're not areas that we psychiatrists have explicit expertise in. And the reverse of that, of course, would be to bring psychiatry specialists into the meetings of family practitioners and other primary care doctors. in such a track, I think it would be a great idea. And I know that there are a large number of very well-trained people in psychiatry that are a part of the Florida Psychiatric Society that would be happy to make those presentations, at no additional cost because they're just so passionate about teaching our primary care brethren.
I love that idea. And then I think about it in a couple of ways. One would be sort of a broad educational, like lecture type format, make sure that, you're aware of this and you're watching for that and screen for this. But then what about even a workshop type setting where more like working with physicians in small groups as far as, practicing techniques like motivational interviewing, perhaps? Areas where you psychiatrists have a lot of expertise in trying to help get into patients' heads to figure out, how they're thinking about things to help them hopefully come up with their own reason to move towards change in whatever aspect they need to improve.
I love that idea. In fact, just an hour ago, I had a conversation with two professors up at the University of Virginia and University of West Virginia who created an Echo Project Hub about 4 years ago. And one of their topics in their seminars was motivational interviewing as one particular example. And one of the techniques that's very specific to the Echo Project is that a presentation is made by a specialist on any topic of importance or need. And then the participants, the so-called audience, in our case, hopefully will be primary care physicians, one or two of them will present a case that they had that was challenging or where they needed some help with. And there would be a conversation between the specialist and the primary care doctor about how the psychiatrist might handle that case. What are the special needs in the primary care clinic? And together they might come up with some ideas that the primary care doctor can then execute without the psychiatrist ever having to have a consultation with that particular patient. And so, if in these meetings of the family practitioners or the Florida Medical Association professional meetings, if there were a way to have a mental health track, if you will, workshops would be a wonderful way to do that type of thing where there might be a brief presentation and then an exchange of ideas about particular cases to make it very interesting.
Yeah, that would be great. So it sounds like the opportunities are one within residency training, two, practicing physicians and figuring out what issues they're running into and more opportunities for education and potentially practicing some skills, and then having access to psychiatrists in group settings where you could run cases, kind of have case presentations and brainstorm about how a psychiatrist might address that issue. And then the other vision that you had was sort of like the pediatric telehealth network, having something similar for adult patients, where I, as a primary care physician, if I had a patient that had, let's say, particularly challenging bipolar disorder or maybe mania, and I wasn't sure what the next step, and I didn't have access to a psychiatrist, I might be able to do a telephone consultation with a psychiatrist to get some advice.
Absolutely, positively so. In fact, when integrated care was first coming to Massachusetts, the pediatric initiatives there were part of what's called the MCPAT program, Massachusetts Child Psychiatry Access Program, and they developed a program where, for example, the folks that staff the telephone hub might involve one full-time equivalent for a psychiatrist, one and a half full-time equivalents for a social worker or a psychologist, a full-time equivalent for a care manager. In Massachusetts, this type of small group was built to be able to service potentially all 1.5 million Massachusetts children, regardless of their insurance status. And that telephone hub is available Monday through Friday, and someone would always answer the phone within 30 minutes of the request. And they provide ongoing education to primary care doctors based on what their population needs. They were looking at kinds of outcomes or addressing issues like what type of question does the pediatrician have about taking care of ADHD or childhood depression? Where can we make a referral by the team coordinator to assist a family in accessing local services? Can the social worker make a referral to provide transitional or interim face-to-face treatment for something that's more acute and needs to be dealt with today or tomorrow? And also, how to access a psychiatrist when more acute psychopharmacological treatment or complex diagnostic formulations are necessary. Those kind of telephone hubs can be very powerful and can amplify the reach of mental health professionals deeply into the medical communities.
Yeah, like I could even envision that this could potentially prevent even an inpatient kind of crisis admission theoretically. If I have a patient in my office that basically, if I don't know, if I don't have a pretty good plan of care, they're going to end up inpatient. So if I was able to access someone to get advice and to know, to feel comfortable, because I know as primary care, I mean, I'm pretty comfortable, of course, depression and anxiety, and even because of the setting I'm in, bipolar and things like that. But I think most of us are not super comfortable with managing like lithium and maybe some of the antipsychotic medications, but sometimes those are things that are really necessary to prevent an inpatient admission.
And yet, aren't you, as a primary care doctor, seeing people come into your office who are already taking some of these medicines as well? And
Absolutely.
and you must sometimes ask the question, well, how come they're not as well as they need to be?
Exactly. Now, in your research that you've been doing about collaborative care, have you evaluated how the pediatric program is going so far, like the utilization and how that seems to be?
You know, Dr. Andres Pumariega, who was involved in some of the McPAP development in Massachusetts and then relocated to Florida, is one of the chief leads on the pediatric programs here in Florida as part of the Behavioral Health Network. He presented two back-to-back grand round sessions recently at the University of Florida, where he described the history and the development of the program and then gave exactly that set of statistics about how it was being utilized, what was being done. I don't have all that details at my fingertips right now, but I know that he would either be willing to share that data or even give his own presentation to the Florida Medical Association in a webinar or even probably in a face-to-face professional meeting.
Yeah, it feels like there's been a pretty good effort to let especially pediatricians and family docs know about the pediatric hubs. And I think that they pretty much incorporate most of Florida at this point, if
They
not
do.
all.
In fact, the newest hub is being built down here, affiliated with Florida Atlantic University. And in fact, Dr. Pumariega is a consultant for helping them get that off the ground. The ones up north around Tallahassee, for example, and Gainesville are already fairly sophisticated. The one out of Gainesville with the University of Florida that Dr. Pumariega himself directs probably has the most experience with data over a 5-year period. And we could definitely figure out how to bring that data forward to any of the listeners here who want to learn about what's been accomplished so far.
So it seems like the money to fund that program's been coming from those schools or from grants from the state.
Yeah, it looks like the funding was at least partly from SAMHSA, and I don't know how much funding was added to it from the universities themselves. Interestingly enough, I just met with my own local representative, Kelly Skidmore, about a week ago. And I asked to see her because both in my capacity as president of the Florida Psychiatric Society and also as a constituent, I wanted to tell her that I and we have a great concern about problems with access to care in the state of Florida, access to mental health care in particular, but that the legislature in the state of Florida has been looking at things like how to expand the scope of activity of nurse practitioners and psychologists, how to give psychologists prescribing privileges, for example, or how to let nurse practitioners practice psychiatry without any supervision by psychiatrists. And this is a prospect that's very frightening to psychiatrists because these people can help with improving access to care, but not in autonomous, independent functioning. They need to be a part of full developed psychiatric teams in order to do this effectively and meaningfully, and most importantly, safely for the public health. So we think that if we could build these networks between psychiatrists and primary care providers directly, we could potentially involve other professionals like nurse practitioners and psychologists, but only once the system is built and we can speak directly to the pediatricians and the primary care physicians.
I'm so glad that you said that because to become a psychiatrist, you're looking at 4 years of college, 4 years of medical school, 4 years of residency, if I'm not mistaken. And then, if you want to take care of children and adolescents, many psychiatrists do additional fellowship training in that. So you're looking at 12 plus years of training to take care of patients, and for good reason, because these are vulnerable patients. They have often complex situations. These medications have potential side effects. So you need to know what you're doing. Nurse practitioners that have a psychiatric designation are only required to complete 600 clinical hours, and of those, they are often required to complete 100 hours with children. And yet, they are being given that responsibility of taking care of patients what they call across the lifespan. You've got a psychiatrist with 12 years that says that's not enough to take care of children. I need to do another year or two. And yet we think it's going to be okay to let someone with 100 hours take care of our most precious commodity, which is children. It just does not compute in my mind.
Absolutely, a frightening proposition to do that without significant medical supervision by experienced physicians. For example, nurse practitioners have been fighting for unsupervised expansion in scope of practice throughout the state of Florida. But we really do think this is not safe and will not solve the access problem. And just as an example, in a recent study, there were more ARNPs that were shown to have moved from rural areas into urban areas than from urban areas into rural areas, where they were claiming to the legislature that they're going to improve access to care in rural areas.
Right. I mean, they're lobbyists, let's say. I don't want to say they because there's a lot of very good people out there, but their leadership and their lobbyists make promises that they can't deliver on and they don't deliver on. And it's been shown in other states and it is being shown in Florida as well. So, really, what we need to be doing is looking at other ways to help our patients get proper care, which is exactly what you're talking about through a collaborative type model and making sure that our patients can get to physicians and that physicians aren't just being replaced with non-physician practitioners.
Absolutely.
You mentioned some studies. I just saw a new report out of New Mexico, and New Mexico is a state that allows independent practice or unsupervised practice of NPs. And they just gave a report that even though they have more psych NPs, their mental health outcomes are actually decreasing. So of course, it's not going to solve the problem by putting a person, just any warm body into place. You really have to have someone that has the proper knowledge and training and education. Otherwise, you can actually cause more harm than good.
Oh my God, is that so true? Think about it. Psychiatric disorders cause more than 25% of all disability worldwide. They cause more than 10% of years lived with disability from depression alone. 3 times as much disability than diabetes, 10 times as much disability than heart disease, 40 times as much disability than cancer. And behavioral problems determine more than 50% of all morbidity and mortality in the healthcare system. Unhealthy behaviors are major drivers of healthcare costs. 40 to 50% struggle with treatment adherence, and employers are struggling not only with absenteeism, but with presenteeism, those who are showing up to work but not well enough to be useful and productive. We can't have unseasoned people providing these services unless they're on a team that's supervised by physicians.
Yeah, I think one of the things that we're seeing is a spike in diagnoses of things like bipolar disorder in children, which really should not be as common as is probably being diagnosed. We're seeing a huge spike in the number of stimulant drugs for ADD, which can be appropriate, but the spike is coming more from nurse practitioners than from physicians in the data that I've seen. We're seeing a huge increase in antipsychotics being prescribed to children, in benzodiazepines being prescribed to nursing home patients. And the data is looking like more of those are coming from people that don't have physician training.
Absolutely. We have got to take the lead as physicians around the country, but specifically here in our state, and make sure that we get our primary care brethren to know how to do this job better, because we could increase residency training slots for psychiatrists, but that's a slow process. We've had some of that accomplished already in the last several years, but that by itself isn't going to solve the entire access to care problem. Telehealth has made a very large step forward in improving access to mental health care. But again, that by itself isn't going to solve the whole problem. So we definitely need to integrate better our mental health professionals and our primary care doctors to do this better. And then where indicated, supervise nurse practitioners and other behavioral health managers to help do that job effectively.
Let's talk about therapy. I know a lot of psychiatrists certainly do therapy, but it seems like it's maybe a little more common for patients to perhaps see a psychiatrist or a primary care physician and then do some therapy with a psychologist or a different clinician. One of the things that I was able to incorporate into my direct primary care practice is to have a psychologist in-house, like in my office every Wednesday. And since I do direct primary care, I have a lot of flexibility with being able to offer lower prices and things like that because we don't deal with insurance. But it has made such a world of difference for me as a doctor because, even in direct primary care where I have 30-minute visits and we know the reality is most primary care visits are not that long, you just don't have the time, and certainly you may not have the training to get into that more therapeutic work that you need to do. So it's helped me so much. And then just my patients, it's amazing watching them progress from being able to build a relationship with a therapist and to feel safe because a lot of times, people are scared. Especially you already have, let's say, anxiety or some other mental health condition. So they come right to my practice and they see the psychologist there in-house. Is that type of collaborative care something that you're seeing or something that you're working on in a primary care setting?
Most definitely. The statistics are that probably at least 50% or 60% of all the people with diagnosable mental health conditions in the United States do not get any treatment for their condition. And then 70% of all psychotropic medications that are prescribed are not prescribed by psychiatrists. Half of those people that are referred for mental health treatment from primary care doctors do not follow through. And if they do follow through, they often can't be seen for a month or 2 months or 3 months to get into the offices of eligible practitioners. To have an embedded mental health professional inside a network of primary care doctors is a wonderful idea. And it's one of the basic tenets even of the collaborative care system, because you can take it a step further. Apart from having somebody there so you can just walk the patient down the hallway into the psychologist's office, you can also employ a system in your electronic medical record where you screen all of your patients for mental health needs, anxiety problems, substance abuse problems, depression, et cetera, et cetera. And then that behavioral health specialist can not only see the people that you walk down the hallway into, but can actually look at the screening data from the electronic medical record and pick out all the other people that are having trouble with their hypertension and their diabetes or everything else that haven't even come to your attention yet because we screen for them. And then he or she will schedule those appointments, will meet with those people. And in a fully developed collaborative care program, the most complicated of those cases will be discussed on a weekly basis with a psychiatrist who either comes to the clinic as well or is available virtually. And such a psychiatrist could review 20 or 30 cases in 4 to 5 hours instead of the 5, 6, 8 people that he or she might see in his or her own office in that same afternoon. So I love the idea of having an embedded behavioral health specialist in a practice like yours.
Yeah, it works well for me because I am out of the insurance model, so I don't have to worry about any of that sort of over like administrative uh, burden, I guess I would say. So that's one of the ways that I can keep my prices low and I can offer a really affordable rate for patients to see the psychologist. It's not quite as easy, I think, in larger groups where you're dealing with different insurers. But you've been talking with some different insurance companies, and you've making some headway, I think, with coverage for collaborative care. Is that right?
Well, apparently, with a lot of work done by the American Psychiatric Association nationally, there have been a number of different insurance companies that have approved collaborative care codes so that if a primary care doctor does something in the mental health arena, like do some screening through their electronic medical record and spend a few minutes discussing anxiety or depression or something else with their patient and potentially making a referral to treatment, that in addition to their 15-minute billing code that they have for that day or the 30-minute billing code, they can add on a collaborative care code that will give them a little bit higher income for having spent the time and motivate them to be willing to spend that time with such patients. And so there are several codes of that nature that have already been approved by several different organizations. I think Medicaid has some approval, Medicare has some, Blue Cross Blue Shield has some. I don't know all the details. I'm not a specialist in billing and coding, but that's something that we could definitely teach more primary care doctors how to engage on that to improve their income and their motivation to ask questions about mental health matters.
Yeah, incentives do matter because primary care is hard, psychiatry is hard, and then it's more difficult when you're dealing with patients that are having unstable mental health situations. And I guess I would say right now feels particularly hard because we do feel so much discomfort and maybe distrust with the healthcare system in general. I don't know if you're experiencing this, but I know I am, and a lot of my colleagues are, just this general sense of, my doctor doesn't listen and they're just trying to sell me drugs, and anti-vaccine sentiment. And, it's a really tough world. And I think it is taking quite a toll on clinicians. So I think we also have to be mindful of that. And I often feel, I think in psychiatry, if I'm not mistaken, you guys do like kind of, is it mandatory therapy where you get to experience what it's like to undergo therapy? I almost feel like we all kind of need it these days.
Oh, absolutely. Because of all the forces in the industrialization of medicine, primary care doctors are getting burned out at rates higher than ever seen before historically in the United States or in the world for that matter. The interesting thing about our conversation today is that I have found in my work with primary care doctors that when we give them some of the tools to be able to do some of the mental health work or at least some of the screening work, that these primary care doctors find it very satisfying because they actually have a slightly different nature to the relationship that they have with their patients. And it's really amazing because not only is it more satisfying for them, but they're finding better outcomes too, because when they're getting their patients treated by themselves or by others for their anxiety problems, for their family problems, for their depression. They're taking better care of their diabetes. They're taking better care of their blood pressure. They're more compliant with the prescription medications for those conditions. And the outcomes are better. And in this era of burnout of doctors, I think that if we could help doctors, primary care doctors, become really fluent in basic mental health skills, they will find it so satisfying and rewarding, and I really want to move this forward.
Would you say that some of those skills would be just something like emotional mirroring and validation? Would that be something that you think, or what are some of the just basic tools that you think primary care doctors should know to be more effective?
That's a great question. Active listening is very, very important. I have a routine I go through when I'm trying to teach residents in my office about nonverbal cues that we doctors give to patients. So the example I give to the residents in training or the medical students is I get up from behind my desk, I go over to my door, I put my hand on the handle to the closed door as if I'm going to open it at the end of a session with somebody, and then I turn around and I ask the question, is there anything else that you would like me to know? And I asked the medical student or the resident what message I just communicated. And they say, well, I guess you're saying that it's time to go. I said, well, yeah, I guess that's true, but the real message I'm saying is Verbally, I asked you if there's anything else you want me to know, and non-verbally, I just told you that if you ask me any other questions, I'm going to beat the hell out of you because I want you out of this office right now. And so, w- one thing I'd like to teach primary care doctors is about the nature of verbal versus nonverbal communications and how to just sit quietly for 10 seconds, look at the patient, and just ask a question and be willing to listen to the answer for 1 minute. Because even in 1 minute, you can learn some things. If you ask a question like, how are things with your husband? Or have there been any special new developments with your kids in school? You're amazed if you give them that 1 minute what you might learn. And you don't have to spend 10 more minutes fixing that problem. You can say, well, can we make another appointment to discuss that in greater detail? Or can I have you talk with the social worker down the hallway who's so good at this stuff?
I love that so much. And it's true, like you feel like, oh, if I sit here and listen, I'm gonna run late. And but actually just letting the person talk makes the visit more efficient and you actually get done quicker than if you're interrupting every 5 seconds.
To that point, I want to introduce another concept. As you know, we're conducting a pilot project with artificial intelligence, and we're using it. There's a company in California that developed a very user-friendly artificial intelligence interview, and they've been working with Sinai Medical Center out in California, and they have loaned us essentially their software interviewing capabilities. And the purpose for this is to let not only psychiatrists, but specifically primary care doctors to make this artificial intelligence interview available to their patients before they come into the office for a new visit or a follow-up visit. And in this process, the AI program uh, gets some information about the person's mental status before the doctor has met to review the blood pressure dosing. And that program can generate a 2 or 3 page report of a 40-minute interview that it conducted with the patient on his or her own time. And the doctor can review that 2 or 3 pages literally in 1 or 2 minutes and learn something significant potentially about the patient, and then say, I wonder if we could set up another meeting just to discuss this matter, not to discuss your blood pressure medicine. Or I wonder if you would be willing to go down the hallway with me and meet the social worker because I want her to talk with you about the report on anxiety that you made.
I'm glad you mentioned that pilot AI program because I did demo it and tested it out a little bit. And what really fascinated me is I was a little apprehensive to present it to my patients. Like I didn't know how they would feel. I said, I'm testing out this new program to learn about your mental health. Every single person that I suggested it to was so eager. They were like, oh, I would love to, absolutely. And I think what it says to me is that people are so yearning to tell their story and to be heard and to be understood. And especially when I tell them I'm using this information to learn more about you so that I can hopefully help you, be as healthy as you can, they welcomed it. So that was very surprising to me because you would think like sometimes you don't want to broach mental health things. You feel like people are going to not want to talk about it. But I'm finding the opposite to be true. And this isn't just our younger generation. We know that our younger generation is so much more open about mental health, which is great. But these are people that are in their later years and they are eager to talk about what they're going through.
It's really an exciting project, and we're hoping that if a lot of primary care doctors have the same kind of experience that you have had, where the patients actually embrace it and like it, and if the primary care doctors find that in that 2 or 3 page written report, they actually learn 1 or 2 things that might be useful for making referrals or for a future visit with the patient. What we're thinking is it could be the basis on building more of an integrated collaborative care program later that can really tap into all of the patients in a primary care practice.
Yeah, any type of tool. It's kind of an amazing time to be in medicine, negative and positives, but the positives being this is the first time that an EHR or any type of electronic system is actually helping me more than hurting me. I'm old enough to have remembered the days of paper charts and pre-ACA EHR mandates. And I mean, they've been nothing but hurtful, harmful, painful, you know, until only now that I feel that I'm using different systems that are actually making me efficient, more efficient. They're not, solving patient problems for me, but they're helping me document. They're helping me think of things that maybe I hadn't thought of, consider more, get more history. So it is a good time for the electronic world in medicine.
Indeed.
I wonder, do you have any other little pearls of wisdom for us primary care folks just helping our patients with mental situations?
I really believe that if primary care doctors would take just a very little bit of time to learn a few basic skills that they don't have already, that they will really find it very satisfying. And I think that it will help their patients be healthier for all of their medical conditions, not just their mental health. But when they see happier, more productive patients, they will really feel good about their contribution in healthcare.
It would be great to outline those skills.
That's an interesting idea. Like, what are some of the things that we could just teach them very, very simply?
Yeah.
What kind of querying questions can you ask? Uh, what can we tell you, like, for example, at the end of your visit discussing blood pressure or the diabetes medicine, take 1 minute, sit there quietly, and say to your patient, we've spent time on a lot of different subjects today. I just want to know one basic thing about you. Are you feeling okay mentally? Uh, is your mood okay? Are there any special problems at home that would be worth us exploring with each other, whether we do it today or another time? And we can teach, questions and skills like that to primary care doctors to how to promote that kind of dialogue and also how to manage it so it doesn't use up all their time.
That's a really good tip. As you were talking about that, I think that what you're describing, a lot of it is mindfulness and being present with the patient in the moment. And that's hard because, of course, your mind is going a mile a minute. You're thinking, I got to order their colonoscopy and we didn't, their A1C and da da da. And I think just taking a minute and just being with the patient. And so one of the things that psychologists have advised me personally and all doctors is to get into mindfulness practice, which I try, and I have to admit I'm not that great at it. But when I do 10 minutes I use Insight Timer and I just do 10 minutes of just focus on my breathing, I absolutely have a better day because it helps me to reset my mind and be mindful instead of letting my mind go on not only what's going on in the patient in front of me, but the 12 million other things that I have on my to-do list. So I think that mindfulness is what you're talking about.
Imagine if we can teach doctors more about mindfulness so that A, they could use the skills for their own relaxation and comfort. And then once they understand the power of it, that they could teach some of that to their patients.
I love it. Yeah, because every day people, I'm so tired, I'm so run down, I have brain fog, and I'm on a little rant against, just social media in general because recently, and maybe I need to get a little therapy from you right now. I just came across one of these online virtual services, and it's a little skit where the lady's playing the patient and the doctor, and the patient saying, "I'm tired and I have brain fog," and the doctor's like, "So does everybody," and the patient's, and my ears itch, and she's like, the doctor's like, "Don't worry about it," and in the comments they were like, "That's my doctor. My doctor never listens to me, and my doctor, and then my doctor only pushes drugs, but I feel so much better now that I'm on these testosterone pellets," and so it's like this cognitive dissonance where it's like doctors only push drugs, but then they won't give us our hormones, and
Right.
here I am like, so much of it is about we try to do too much. We burn the candle at both ends. You're trying to be a perfect mom and doctor or professional or whatever. And then you wonder why you're tired. It's not to say it couldn't have a medical cause, but so much. It's just we're doing too much and our brains can't handle it.
Absolutely. We could really, psychiatrists get some training in how to manage things like this. And we could share some of that training with primary care
Yeah,
doctors.
like I need it right now. Actually,
That's
this has
great.
been a great conversation. I came into today like I've had a week, I've had a week. And I'm like I'm kind of in a rotten mood and like I hate everything and everybody and actually feel a little better right now. There's something to just just talking about what you're going through, having a kind voice say, "Yeah, you're not alone and, let's work on it." Um,
Absolutely.
this is the therapeutic relationship that primary care doctors and psychiatrists bring every day to their patients, and it is valuable and it is important.
And with the industrialization of medicine, we've lost some of our ability to do that.